Alrighty, yes, everyone, welcome back to those of you that have attended previous ones. We appreciate it. So happy to be here with you today. So just do a brief little recap on my intro here. Ali Wahadville, LCSW. My pronouns are he, him, el. And just throwing it out there, I've been doing this work for 9 years, doing clinical social work. However, the last 6 years have been with crisis response teams, with programs such as Wraparound, the Safety Mobile Crisis Unit here in Santa Barbara, as well as working with CSEC populations specifically, and currently in the clinic at the Isla Vista Neighborhood Clinic here in Santa Barbara. So for today's work that we have, I'm going to be kind of just shedding some light on how I've used this tool that we'll be teaching you all today in my work. And, you know, I do think that this approach kind of helps us make strong connections with those that we're working with. So we're excited to kind of have discussions with you all today, and I'll hand it over to Bella.
Thank you, Ali G. Hey everyone, my name is Bella Restrepo. My pronouns are she, they. I identify as a non-binary femme. And first of all, thank you all for being with us today. My kind of positionality here is I'm a researcher at the University of California, Santa Barbara. I look at the criminalization of marginalized communities, especially through the lens of mental health. So what my work focuses on is what works and what doesn't work for marginalized communities. What mental health practices, what care practices have been useful, what care practices have been detrimental. The current project that I'm looking at unpacks the criminalization of Latina foster girls. So that's kind of my focus right now, and it will be for about the next year while I finish out this project. But generally, my research looks at criminalization and mental health. Meg, thank you so much for sharing. And that reminds me that I haven't responded to your email. I will do that this week. Feel free to send me a follow-up to bump it back up, please. All right, team, let's get into it. All right.
Alrighty, so for part 4 of 8 series, we'll be reviewing assessment tools. The tool we'll use today will be helpful for understanding the unique experiences of the people we work with in our community, specifically gender diverse populations and BIPOC POC. And we're hoping that the tool we talk about today will help us understand what we bring into the room, as well as what identities the folks we're working with may be navigating. I think in my work, often I see that for LGBT communities, there's often seen as a monolith, but there are nuances based on identities like race, gender, disability, social economic status that create a unique experience for queer and trans folks. So today's session will focus on learning how overlapping identities and experiences impact folks in distinct ways. So overall, how do these identities contribute to stressors in their life or factors that may be impacting their mental health? So the agenda for today is that we're going to start off with a knowledge share kind of just regarding assessments. We're going to take a look at things to consider when entering a crisis situation, overall increasing self-awareness. And we're going to review the tool for an intersectional assessment using the addressing identities model. Some of you may be familiar with that model, but we're just going to kind of unpack that in discussion with you all today.
Yeah, and really what today's session is going to focus on is actually some of the feedback that we've received most consistently, especially in thinking about the needs assessment that you all filled out in the first session. So when we asked you what you needed to feel more confident in responding to crisis, the things that came up most consistently were a continued understanding of our own positionalities of this work and how we can reduce the harm that we as respondents, as paraprofessionals, as mental health workers cause. People asked for more insight on cultural humility, on more insight in how to be able to keep ourselves in check, right? So this kind of self-assessment in addition to assessment of the people that we work with. When asked what you hope to get out of this training, you said that you needed support in figuring out how to train more culturally responsive respondents. You're looking for more culturally competent services and supports that meet the needs of marginalized communities and marginalized youth specifically in your communities. You asked for new ways to approach the work that fosters inclusion and reduces the possibility, again, of causing harm. And so today's session is really going to focus on how we can incorporate cultural humility and how we can conduct assessments that include self-awareness in really kind of intersectional, nuanced ways. Part of what we will be discussing today is how we can incorporate these kind of intersectional tools even when we're not conducting an official assessment. So for the people that do conduct assessments, these questions are more geared towards you. So what does your agency ask for in assessments? In my own work, right, is this kind of feeling of ostracization because of the assessments. You know, clinicians going through a checklist and having this process feel like something that is really impersonal, something that is really kind of institutionalized. So I appreciate the focus on figuring out where people are as opposed to, you know, this checklist that our agencies require of us.
Yeah, and I like Meg, you're actually, you know, to identify strengths, right? And I think that's something we're seeing more and more, at least on my end, where I have done Medi-Cal comprehensive assessments. And here at our clinic, that is one part of the assessment there is what are the strengths that we're looking at? You know, in addition to what are the stressors, what is the diagnostics, what's treatment going to look like? I like that you just mentioned kind of identifying strengths. Will, welcome back. So happy to have you here, creating connections. To better meet a person where they are, right? That's kind of social work ethics right there. Meet the person where they're at. All right, I love all the responses here. Ariel, assessments help us understand where the client is, where we can meet them. Yep. Trauma-informed ways, right, to help us figure out what types of services are needed. Again, kind of gathering historical information, whether that's demographics, what traumatic events have they navigated, you know, what are the behaviors and perceptions, impacts, impairments going on, and then what are the strengths they have and how can we determine a treatment plan or determine what resources are needed. So I think these were great responses. I think you all understand the importance of an assessment and why we even conduct assessments. And kind of like Bella is saying, assessments can often look like a checklist, but I feel that we can be most, you know, get the most information when we can make this a conversation. And that's just feedback that has been given by, you know, foster youth that I have worked with when I've worked in the clinics here at Behavioral Wellness. That was often the feedback, right? Don't have it be a checklist. I've seen this happen in my work where someone goes in with the checklist and, you know, the patient or the client, in this case, it was foster youth, are just kind of yes, no, not really giving answers you want. And then you walk out with a diagnosis of ODD because they did not want to answer your questions and you really don't have a lot of information to determine an accurate or appropriate diagnosis. So you go with, oh, they were resistant, they didn't like authority. And I've seen that be very common. And I think that's come up in Bella's research as she works with foster youth as well. So we're hoping that today's conversations that we have help us have more conversations and think of that big picture as opposed to the information they're giving, right? I have worked with foster youth where they tell me, oh, I don't have, when I do the checklist, I'm not sad, I'm not depressed, I don't have loss of concentration, I've been good. And then with somewhere in the assessment, we get to, oh, wow, you were removed at 12 years old. Tell me how that impacted you to have, you know, to be taken away from your family. And then right there, I'm actually gathering more information than when I went through with the checklist. So a good assessment includes us being able to bridge these gaps to make sense of what has happened in their life and ask prompting questions from there of, oh, okay, how did this impact you? Oh, you say you are one of the few Black members in your community. How has that impacted your feelings of connection? Who do you associate with?
Yeah, so when we're thinking about assessments, I think that one of the most difficult things is that each agency has its own kind of requirements around what the assessment needs to ask. A lot of agencies already have preset assessments. And so what we're going to be doing today is we're going to be sharing some tools with you, regardless of what the format of your assessment is. These tools will be helpful for you to learn how to maybe go into more in-depth explorations in the assessments that you do conduct that may not be facilitated by the format of the assessments that you currently have.
Yeah, one last thing I want to say, Bella, before we go into the next is that very often, you know, whether it's our agencies or the templates we're working with that are asking for us to gather information about trauma, right? And that is one area that if we are going to be trauma informed, we have to be cautious of how we ask these questions, because again, thinking about our session last cohort where we learned about the brain, right? That when we activate someone's emotion, we're actually activating the memory center of the brain. And when that memory is activated, the person can feel that feeling as if it's happening now. So when we ask someone to tap into trauma, we have to be mindful of what's the world they're stepping out into. And I think of a moment when I went into juvenile hall where I had to do an assessment on a girl who was identified CSEC. And I was expected to do the comprehensive assessment for Medi-Cal, which required me asking about trauma and suicidal ideation. And I remember in this assessment, she looked at me and she said, "You really think I'm going to tell you what I've been through when I have to step back and go into my cell by myself?" And it was a moment there where I was like, that's a very good point. Here I am asking this question, not recognizing you're about to be isolated in confinement with no access to any supports or connection. And here I am tapping into your trauma. So I think when we do these assessments too, as much as we need to get that traumatic history or the ACEs of someone's life, I just want to emphasize that it's very important that we just kind of be mindful of like, where are they going after that assessment? What environment are they stepping into, so that we don't activate that trauma just for the sake of Medi-Cal needs to know what your trauma is. And I'm using Medi-Cal because that was my experience there, but just wanted to throw that out there before we move on.
And Ali, in those situations, how do you respond? So if there is a question that is asking you to, tap into somebody's trauma and they're not in a space to be able to share that, what do you put in your assessments as opposed to actually responding to that question?
So I'll actually always ask it, and I always let someone know, this is standard. It's a question on my template. I do have to ask this question, but I want you to know that you do not need to tell me this today, tomorrow, any other day that I work with you, until you feel safe and you feel ready to tell me that. And then I also give them the disclaimer because, we don't want to open up that jar of memories right now if you are having to go back into this environment. And then what I'll write in the assessment is something along the lines of, this was first session, clinician will gather this information and follow up. Or, with the girl I was speaking about earlier, patient disclosed that, she did not want to share because she was going to be going back into her cell where she felt isolated and already had feelings of suicidal ideation. So that is kind of one little disclaimer I put in there, but it's really like just putting a pin in it, saying, not that I'm not going to gather this information, but I'm going to do it at a later session when I have more rapport, when I have more trust, when I've assessed coping skills and environmental factors, that I will do that. But that's a great question, Bella.
All right. Thank you all for indulging us in this assessment conversation. If we can move on to the next slide, one of the things that we really wanted to cover was, when we talk about assessment, we very often think about it in terms of the people that we work with, and without also recognizing how important it is for us to be engaging in a kind of a system of constant self-assessment. So when we're stepping into a crisis situation, when we're stepping into an assessment even, there are things that we have to be considering about ourselves. So things to consider in the work that I've done, the things that have come up most consistently is a need for providers to be more aware of themselves. So what does this mean, right? This is, questions like, what am I bringing into this space? And what this is really asking us to think about is, what are the feelings? What's the energy? What's my headspace? What's my mood? Do I have feelings about this situation already before I'm even stepping into it? Do I have, for example, preset thoughts? Do I have ideas? Do I have responses that this situation is bringing up to me? Maybe I have an experience with a similar crisis situation that, is maybe bringing up big feelings for me. Do I have thoughts about this particular demographic that could impact the work that I'm doing? Are there particular behaviors that are at play here that are especially triggering to me? And I think that what I found in my one-on-one work with clinicians is that there's this difficulty, right, around recognizing what am I bringing into this space that could impact the outcome for the people that are involved in this crisis, right? Whether it's the client, whether it's me, whether it's my team. So being self-aware of ourselves in crisis situation has to be one of the first steps that we as individuals are taking, because unfortunately, right, we operate under this myth of objectivity, right? We think that we're stepping into this crisis situation and often we're not bringing in our own emotions, even though we're all humans, right? That's impossible for us to do. We're all stepping into every single situation that we're a part of with our own ideas and experiences and socialization that impact the ways that we move through those situations. So in order for us to be, at least what I've learned, right, from the youth that I've worked with, is that in order for people working with youth to be able to conduct thorough assessments, to do really good kind of self-aware work, we have to be aware of ourselves. And then in thinking about, the way that our embodiment impacts a situation, and this could be a lot of things. And Ali, I'll pass that over to you. I think you have some really good ideas around embodiment.
Again, just building off what Bella is saying here, but kind of just to paint a picture, right? If you are walking into a situation, whether it's a crisis, whether you're having to do an assessment or you're just meeting a family, that person, we have to take into account what experiences they've had. So for example, in some of the work I did with wraparound, we largely worked here in Santa Barbara. We have a big population of like white and Latino population, pretty big here. However, a lot of the clinicians are often white here in Santa Barbara. And so very often when I'd walk into a situation, whether it was taking over a case from a clinician who's passing the case over to me, I walk in and I'd very often hear like, oh, well, we weren't really going to be honest, or we didn't feel comfortable or safe enough to be ourselves when the clinician was white. And it's not to say that if you are of a different identity that you can't do that work, but it's very important to kind of acknowledge the intersections of your identity just as much as it is for them when you walk into that room. So here at the clinic, there are times I go downstairs to speak with a patient who's just disclosed maybe sexual assault, right? And I'm walking in and I've had a few women tell me, I don't feel comfortable talking to you. You're a man and, this is triggering my assault or just experiences I've had. So that's, again, kind of taught me that when I enter these situations, I need to be acknowledging the layers of my identity. So very often that is, how do you feel working with like a Latino trans male? How do you feel working with a Latino male? And it's very interesting because it allows for a good discussion. Some people are like, no, I'm fine with it. And others are like, you know what, that's a good point. I don't feel comfortable talking with you. I'd like to request a female therapist. Or it creates a conversation around, well, yeah, I've had some, struggles, in male relationships, but I feel it could be a good thing to work with you because maybe you can provide a different experience. So those are just kind of some examples there walking in. And I think the trait of a good clinician is to have cultural humility, which defined by the National Institute of Health is, again, just kind of a lifelong process of self-reflection, self-critique, whereby the individual not only learns about another's culture, but one starts with an examination of his or her own beliefs and cultural identities. So kind of just always walking into the room and being willing to own those identities and have a discussion about it can allow for a more honest conversation. Because again, when you walk in and you are, a trans man and you're going to be working with a religious Latino family that maybe has, preconceived notions of that, best believe that is going to impact the information you can get, the relationship you can build. And so I'm not sure if that answered your question, Bella, there, but I guess I'm curious to hear if anybody wants to share an experience where maybe they walked into a situation and, based on their layers of identity that might have impacted a situation, again, in a good way or a bad way. Kind of like last session we had, some of you said, that when you talk with trans youth, you often try to bring in folks that they can see themselves represented in, right? So that's you kind of being like, I know you're probably not going to be open talking to me, but let me bring in a peer that you can relate to, or someone who's within the same, race or gender or sexual orientation that can allow that conversation. So you all already doing that, but just wanted to ask if anyone wanted to share any experiences they might have had.
While y'all are thinking about that, I also wanted to say that in the work that I do, what's come up so often is not that, if we are of a different identity, we can't do good work, but it's an unwillingness, right? From clinicians, from paraprofessionals, from other people that are in the helping professions, an unwillingness to talk about these differences, right? So like Ali mentioned, we work in Santa Barbara County. The population of clinicians here is largely white women, white cisgender women. And in the research that I'm doing, what is coming up consistently is a discomfort with naming the whiteness that is in the room, right? What is it like for you as a family of color to be working with a clinician who is white? Are there things that you feel like I'm not getting? Are there things that you need me to learn more about? There's this difficulty in even naming these things, so that if a family, if a client, if a community member is feeling these things, there hasn't been an opportunity for them to discuss it with their clinicians because the clinician hasn't named it yet. Will says, cultural humility is commonly misused to justify oppression, dismissal, and marginalization. I've experienced the empowered white women telling the disempowered to practice cultural humility by not challenging them on race or other cultural areas. Will, this is such a good point, right? Because this is exactly how we don't practice cultural humility. And this is exactly what we're kind of naming, and this unwillingness to discuss it, this unwillingness to name it. That's actually the exact opposite of cultural humility, right? And especially if we're thinking about conversations about cultural humility through an intersectional lens, this requires that we acknowledge the power dynamics that are in the room, right? Not that we ignore them, that we actually engage with them, and that we figure out if this isn't working for the people that we're working with, then what changes do I have to make? Whether it's about what I have to learn, or it's about bringing in other people who can do this work in a more nuanced, supportive way. Thank you, Will. That I think is a really important point, because this language very often does get kind of wielded against marginalized communities in really harmful ways. So the questions that are in the self-awareness slide are really big questions. You know, I think that they can be really difficult to engage with, especially if we haven't had these conversations before. So what we want to do is we want to offer you all a tool, and we want to review this tool collectively. And this tool is really meant to help us figure out how to have these conversations. It's a worksheet. It is it's the starting point of ongoing conversations that we should be having with the people that we work with around things like, oppression, power dynamics, privilege, and all of the things that we are also bringing into the room. So I'm going to quickly share my screen with you to show you one of the resources that is available to you on the link tree. And so many of you are probably already familiar with this. This is the Addressing Identities model, especially if you're MFTs. I think MFTs use this a lot. And so this has, I'm just going to look at the chat real quick. Thank you so much, Ruth. So you could find this tool at the link tree that Ruth just dropped in the chat for you all. So the Addressing Identities model is something that MFTs use pretty often. This is really a foundation, and it doesn't have to be the end of our engagement with intersectional crisis assessment. Instead, I want us to think about this as a tool that can help us figure out how to explore these kind of contours, these nuances of identity, of oppression, and of the ways that people move through the world. So we don't have time to go over it entirely, but I do want to review it with you really quickly. So the Addressing Identities model goes over things like age, disability status, diagnosis, religion, indigenous heritage, sexual orientation, and a number of other overlapping identities. And if you have some time, I think that this tool can be really useful, especially for folks that are looking for ways to train more culturally competent clinicians, paraprofessionals. So it gives us a little description of what the identity is, and it identifies dominant and targeted identities for us. So when you have a minute, go over this. If you have time to do it with your agency, that would be amazing too. And if we scroll to the bottom, I want to show you really quickly that there's a section for us to actually fill out these questions for ourselves, right? And this tool is really helpful for us in gaining more self-awareness around what we're bringing into the spaces that we're a part of. You can use it with the people, with your community members as well, the folks that come to your agencies. But this is, in my opinion, this tool is a kind of starting point for our own self-awareness. So the questions that it asks is, for example, age. How does this identity influence how you think and behave? How does this identity influence how others may think and behave towards you? And how often do you think about this identity? And really what this is helping us do is figure out our own positionality in the world. For many of us who do come from privileged backgrounds, right? As a light-skinned Latina, there are many things that I haven't had to think about because I'm not navigating the world as somebody who's dark-skinned, right? So I'm not dealing with things like colorism in the same ways as other folks may be. So because of my privileged identities, there's so many things that I've never had to think about. The more work we can do in reflecting on what we're bringing into the space, the more thorough we can be in the work that we're doing with our communities. So if you have a minute, please take some time to look over this with your agency if you can. And in the link tree, there's a more simplified version of this that you can use to conduct assessments with the people that you're working with your community members. You can give it to them to fill out for themselves. It's just generally a helpful tool for helping us learn about ourselves.
Yeah, again, like Bella said, this can be helpful for our patients. This can be helpful for us. And I just want to share an example of how this kind of got used in a conversation with my supervisor I was 2 years in here at Santa Barbara, and I was noticing that there was a big disparity with our probation youth, where Latino and Black probation youth would violate and they'd get another 6 months. And then I'd see the same kind of behaviors take place with our white population, and the judge was often very lenient with kind of the consequences. They wouldn't get reviolated. It was just like, oh, we understand he's having a hard time. Let's just see it. And so I brought this up in supervision to my white, cis, hetero, very wealthy supervisor. And she just looked at me like, no, 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 it just so happens to be your caseload. And I'm going, well, no, it's something I've seen across the board. Anyway, she came back that following session to our next supervision, and she said, you know what you shared with me, I had to think, I had to reflect on my life and my privilege. And she said, and I want to say that you are 100% right. And she said it, as a white, privileged, cis, hetero woman, I do not see the things that you see. I have not had to move through the world in the way that you have. And that was a moment there where it built our relationship, where it became that much more trusting of her, because she was willing to identify the layers of privilege that impacted the way she saw the world, the way she saw our youth being treated. And it was just a moment there where, again, that cultural humility was there, where she said, you know, I don't know what you're talking about, but I'm open to learning. And she did some research, and she actually ended up going to get a PhD in like learning about like trans identities. And it was just very interesting. But again, even as a supervisor, just kind of owning her privilege to me did something. It made me trust her more. And so if I think about that kind of a parallel to like that coming out in a therapeutic relationship, it's like, wow, you can imagine the power, that much more trust the patient or client is going to have in you when you can identify these things, right? And in working with the trans population, I'm one of 3 trans therapists in Santa Barbara County. And there is an agency that works specifically with LGBT populations, but all of their staff are just lesbian, gay, maybe not trans. And I've had a few patients come to me saying, yeah, although they may be lesbian and gay, they do not understand the trans identity, and nor are they willing to acknowledge it. So again, like even if we don't have all of these identities, if we can own our own privilege, it creates that much of a better therapeutic relationship. But I know we need to hop on over to the next stuff.
So we can get the slide deck back up, please. We can start off at slide 11. So, you know,
sorry, Bella, Ruth, can you give me screen sharing ability again? Thank you.
Yeah, no problem. So as they're pulling up the slides, you know, I think that the things that we're talking about, I feel like can sound really abstract. You know, it can be this conversation around, you have to acknowledge your privilege. You have to be aware of these things without really kind of figuring out how we do that. So what we want to do is we want to actually go over the identities that are named in the addressing model, and have a group discussion about what we need to consider, because there are so many things I think that you know, we have ideas about what we need to think about when we're thinking about something like age, but the experiences of somebody who's maybe an elder are so much more nuanced than many of us even realize. So we want to have a group discussion that kind of looks at these identities, and we have, you know, not too much time left, so we're gonna focus on a couple of them and skip over a couple others. So if we could start with age and generational influences. When we're thinking about age and generational influence, what have y'all found to be important things that we need to consider when we're working with someone who is marginalized with this identity? These are kind of guiding questions, right? But what are the important things that we need to be discussing, that we need to be figuring out, that we need to be acknowledging? Maybe what types of hardships, if any, may folks marginalized within this identity deal with? We'll give folks about 30 seconds to think about this. Feel free to drop it in the chat.
I think the chat's been a good way of getting that information out, where we're not speaking over one another. So yeah, if anyone can think of an example in your life personally too, right, where age has maybe impacted you in a way.
Right, because also, you know, part of this is also recognizing that we all have experiential knowledge, right? So even if we're not clinicians, we all have experiences with things like age, whether it's our own experience, the experiences of our family members. What do we need to be considering?
Right, I know for myself, I look young, not that I am young, although I'm middle-aged, I'd say, but you know, I hop on the screen to meet someone on Zoom, and very often I have had, you know, older folks say, why'd they give me you? What are you, like 19? in your early 20s. And I'm like, okay, right. So they're having a judgment of me. How can you help me when you look so young? And I had women say, why would they give me you? I'm like 56. And I'm like, well, you have depression and I work with depression. So that's why I'm here. But yeah, that's one way that age has kind of impacted my relationships and working with folks. And then on the other spectrum, right, working with the younger generation, working with youth, my favorite population, they're always like, oh, wow, like, I feel like I can relate to you because you're so young. I had in New Jersey, my supervisor was like, this kid in the group home wants to switch therapists because he thinks you look young and you'll understand him more. Because he wanted to talk about sex. He was 19. He wanted to talk about sex, and she often wore a necklace with a cross, right? So he felt like, first of all, you look old, and these were his words, you look old and you're religious. So I want to work with him. So that was one example of just how age impacted in the positive and in the not so positive. But again, not that I was not able to do that work. It was a conversation. Well, how do you feel working with someone who's younger?
If we can move on to the next slide, a couple of other things that we need to consider is what have they lived through, right? I find that, very often we kind of skim over the kind of historical happenings that people have navigated. So if we're working with, queer populations, for example, were they a gay man who survived the 80s, right? Did they have to navigate the AIDS pandemic? What did that mean for them in terms of the way that they relate, or the way that they move through medical systems, for example, right? Because we know that there's a lot of medical trauma that's based in experiences of surviving the AIDS pandemic. We have to look at, for example, poverty levels. We know that aging populations experience much higher levels of poverty. So what access do they have? Do they have access to their medical needs? Do they have access to consistent therapy? Do they have access to transportation to get to their medical needs? And then Mariah says, as a youth advocate, I think there's a lot of bias when working with parents. I'm often disregarded when sharing personal experiences due to my lack of parental experiences, which makes it difficult to create effective interventions to address client needs. I think that Ali can speak directly to that.
No, that's kind of what I'm talking about, right? That's a great example of like how age can impact the work we do, right? There's a notion that you're not a parent, so how can you help me?
Yeah, and so often, there's this kind of this fear of naming those things. And Mariah, I really appreciate you saying this, right? Naming this in the chat. Because when we don't name these things, right, they impact the room whether or not we're talking about them. And then Will says that top bubble about BIPOC seniors is often rejected and neglected because older people are expected to have everything together and have acquired homes, cars, cash, and having it quote unquote together. 100%. And when we think about things like systemic racism and inequitable systems of economics and of housing, then we know, right, that BIPOC seniors actually experience things like houselessness, lack of transportation at really, really high rates. And so when we have these kind of preconceived ideas about what it means to be an elder, there's so much experience that we miss out on. And so when we think about things like this, it doesn't mean that you have to know everything about, the aging populations, but what it does mean is that you have to be willing to prompt those conversations so that they can name their experiences to you, and we can figure out, just like you all named, right? What's the best course of action for this person? What resources does this person need? What community members can I connect this person to help them feel like they are part of a larger community?
Right.
All right, thank you all.
In seeing folks with depression, a lot of what comes up is, oh, I'm reaching 50 and I don't have these things, right? So kind of like age kind of has expectations that should have been met. By 30, I should have had, and these are a few Latino women I'm working with, I'm in my mid 30s and I should have had children, and they're depressed and they're like, I haven't found the one that I'm going to marry. And so it's like age creates these pressures that contribute to our mental health. And so a lot of the work I've done has been helping them unpack that, like, hey, just because this is your age does not mean we need to have like a checklist of milestones that we've met. But the world does put this pressure on us that age should come with these kind of expectations, kind of like Will's talking about here.
100%. And with all of these categories, we have to be thinking about intersectionality, because if we think about, for example, women who are elders, right, we know then that Women make up 55% of seniors. They have lower incomes and they're more likely to live in poverty. So when we're thinking about every single one of these identities, we have to be thinking about them from a nuanced, intersectional, overlapping lens. All right, so while y'all are thinking about that, we will go over what we have here a little bit. So when we think about, again, the intersections of disability and gender, right, that we know that women who experience disabilities are at an elevated risk for depression. So this means that assessments that are based in things like mental health have to be considering the disability and the physical health status of the people that we are working with. And, I think that this can be a really kind of, again, abstract concept, right? But what, again, this points us to is a willingness to explore these topics. And the reality is, that being able-bodied is a temporary state for all of us. At some point, if we have the privilege of aging, the majority of us will experience some form of physical health disability or a mental health disability. This kind of topic of exploration, I find that people often shy away from it, right? There's this kind of unwillingness to explore something like disability if the person doesn't present with a outward physical disability, but there are so many disabilities that are invisible. So when we're not exploring this topic, when we're not asking folks, what's your physical health status like? Do you have any difficulties in navigating the world in relation to your physical health? When we're not asking these questions, there is a whole kind of category of experience that we're not allowing people to name for themselves.
I want to say too, like, again, working here at the clinic with doctors, I often get referred, again, because we're here in Santa Barbara, Latino males have come to my office or have been referred to me due to physical health status, right? And it's like, they're 33 years old and they've already had a heart attack, or their blood pressure is so high because stress will impact like physical health. And that kind of goes to like the ACEs study, right? That found that those that have more adverse childhood experiences will have more health issues as they age at a younger age. So that's just kind of one example for me that I see physical health status, at least for like the Latino males that I work with that have higher blood pressure, strokes, heart attacks at early age. But again, I just want to provide an example of, like, I think you might have said this already, Bella, but like just working with, like, for example, a trans woman of color who's already laboring under transphobia and racism. She would be especially impacted by something like a disability because of the end discrimination they will experience will come from several intersections of her identity, right? So she's navigating being a woman of color, she's navigating being a trans woman of color, and then if there were to be a disability, like, we can just, again, kind of see how these things can really impact her mental health.
And Paula, I think, is pointing us to exactly this, right? She says that disability makes everything harder. Higher rates of unemployment, there's more poverty, there's more difficulty getting housing that works for folks with disabilities, higher healthcare needs and costs. And if we're thinking about the higher healthcare needs and costs, right, what would this mean to a family that's also navigating something like poverty? We know that accommodations for disabilities can often be really expensive to implement in our homes. So if this family is also navigating poverty, what are the kind of barriers to access that they are dealing with as a result of disability in conjunction with poverty? And people that are experiencing disability and issues around their physical health status also have higher rates of mental health issues, right? This includes something like suicidal ideation. And Paula, again, is pointing us to this. She says that as a friend losing her sight said, there are also these hidden layers of disability because losing her sight has created anxiety, it's created depression, it's created anger. This increases people's experiences with mental health, it increases SI. So there are so many things that we have to explore when we're considering disability, right? How disclosure may impact employment status or opportunities. This is incredibly important. We have laws in place that protect people with disabilities, but so often, right, these laws don't actually do the things that they are meant to do. So even with these kind of protections in place, we see that people who have disabilities experience significantly higher rates of unemployment, of workplace discrimination, of inequitable hiring practices. And so there are so many ways that disability creates these kind of opportunities of poverty, right? This reality of poverty for people who are navigating physical health issues.
That disclosure of a disability may impact the employment status or opportunities. So just kind of what you were hitting on there, Bella.
Yeah, just thinking about, so they say the challenge at times is relating the information to them. The best tool for me is being able to explain new skills in a way that is easy to understand and apply to their life, right? And so I think I really appreciate this, right? Because what Luna is pointing us to is meeting people where they're at, right? So what are people's cognitive abilities? Am I presenting the information in a way that is helpful for them, in a way that is understandable and comprehensive for them? And if I'm not, right, if the folks that I'm working with aren't grasping this, then what changes do I have to make in the way that I'm presenting this? And then Joanna says that going post-pandemic virtual for an annual event I run, I've been reminded about how having closed captioning options. I've been super appreciative of other organizations, including this in trainings and events that they host. And I think that this is important because what the pandemic has shown us is that we actually do have the ability to create accommodations for people who are navigating disability. But it's part of the issue that we deal with is that with so many able-bodied people, these are things that we're not thinking about. We're not even considering in the ways that we're setting up our organizations, the ways that we're setting up our conferences, or the ways that we're setting up the interactions that we're having with people. So thinking about in what ways can I make my agency, or like Luna says, the information that I'm sharing more accessible to the people that I'm working with. And this doesn't mean that we have to know everything, but what it does mean is that we have to be willing to ask, is this helpful for you? Is there another way that I can give you this information that would be more beneficial to you? Being willing to ask these questions that sometimes we just kind of skim over. All right, thank you so much, folks, for your participation. Let's move on to the next section. Diagnosis status. There is so much to consider when we're thinking about something like diagnosis status. So I'm gonna give folks a minute to reflect on it.
Yeah, and I think the chat's working really well. So for those of you that are, dropping knowledge in this, I appreciate it. It's definitely helping the discussion.
Yeah, and honestly, what this tells me too is that, the group that is in here is also a resource, right? It's not just like these resources that are on the link tree, but all of your own experiences and the knowledge that you're dropping in here is also a resource for all of our colleagues to be able to learn, to continue learning. So I really appreciate all of the gems that everybody's dropping. All right, and if we can move on to the next slide, I'm going to read out loud what Will said. And Will says, I can see several of my peers' eyes bugged in surprise or even weeping just seeing this and knowing somewhere out there gets it. This is an incredible opportunity you're offering providers by sharing this information. The potential pitfall is having services in place and following through once folks open up. This is such a good point. Will, what you're really pointing us to is a lack of resources, right? Because we can have these conversations and then what happens post-conversation? Do we have resources in our communities that can assist people who are sharing these kind of difficulties with us? Very often, in Santa Barbara County, for example, we're dealing with the housing crisis. So even when folks are naming, I'm dealing with poverty and I can't find housing, there's so few resources for us to be able to refer people to. So Will, I really appreciate this insight because I think that this is probably something that people across counties are dealing with, which is really a lack of resources. And then when we're thinking about folks that are navigating mental health diagnosis status, especially for people that have severe mental health diagnoses, we know that people who have mental health diagnosis are going to experience criminalization at about 10 times the rate of the population that doesn't have a severe mental illness diagnosis. What this means is that our current society, and this is thinking back to the conversation about criminalization, we don't have a model of dealing with folks that are navigating severe mental illness. Our model currently is based within criminal justice systems. It's based within incarceration. It's based within systems like probation. And what we've seen time and time again is that these systems don't support people that have severe mental illness. In fact, it can often exacerbate that severe mental illness. What else do we have to consider?
While you all are typing in the chat there, I want to say, again, working here at the clinic with trans folks, where very often to get set up with hormone replacement therapy, to be given letters for top surgery, bottom surgery, overall gender affirming procedures, it requires a diagnosis of gender dysphoria. And some patients that I see get it. They're like, yeah, I know it's something you have to do. It's fine, right? But for those that are new to seeking HRT or want this letter, very often a diagnosis can serve as kind of the gatekeeping, right? So some clinicians will say, oh, well, I need like 4 sessions with you to determine if your gender dysphoria qualifies you for a letter. And so I want to say that just kind of seeing that diagnosis be used as a way to keep people from getting the help they need. Because again, like trans folks will say, I don't need 3 sessions to convince this other person that I need top surgery, because if I don't have top surgery, I'm going to kill myself. Gender affirming surgeries are essential. They save lives. So just kind of thinking about how gender dysphoria has been used as like, you need to have a diagnosis can be problematic, and it shouldn't have to be that way. And that's very often the conversation I have with folks too, right? Like, I'm having this meeting with you. I need some information to write your letter. We don't need 6 sessions. I'll get it done by the end of the session. But I do need to have this discussion with you. And again, it creates a conversation about, just society. Like, yeah, why? And then if you look at the DSM for gender dysphoria, it's like desires clothing of the opposite sex or gender, desires toys of the opposite sex and gender. And it's like, I've had conversations with 13-year-olds that when I'm screening them for these things, they're like, well, what is a girl toy and what is a boy toy? And I'm like, you're so right. And again, these are social constructions. When I speak to this diagnosis, I am not saying this. This is a book that I have to like do a checklist on, but it creates good conversations around that. So I just wanted to point out that like gender dysphoria is often a diagnosis that can be very problematic, but again, can allow for some great conversations. In addition, I want to say working with foster youth, right? Where when I would assess them, I'd ask them, hey, I'm like the 5th, 12th therapist you've had. What are some diagnoses you've had in the past? I don't know. I've never been told. And I'm like, oh, wow. So you've never really been educated on like the diagnosis you have. Or they'll be like, oh yeah, I'm just oppositional. That's just how I am. And it's like, well, no, let's unpack that. Like, why do you feel you're oppositional, right? And then we talk about like, oh, you were removed from home by law enforcement, by social workers. So it's not so much that you're oppositional, it's that these things are like a trauma trigger. Like meeting probation officers and social workers, it's not that you're oppositional, it's that these people have impacted your life in a way that you don't fully understand yet. So just again, kind of the pathologization of like ODD can lead to people not fully like understanding how situations have impacted them. So again, when we think about assessments, or when we think about building relationships with the folks we work with, these are important conversations to have. That diagnosis for all of the little bubbles here, but also just creates conversation for more in-depth conversations about what one is navigating, instead of just saying, well, you're just oppositional or you just have ADHD. Like, no, maybe you've experienced trauma and that impacts our ability to concentrate and focus and puts us in survival brain. So it can mirror ADHD, but it can be worked on. So this way they don't become adults that have just said, oh, I just don't have the attention span, I have ADHD. Because I see a lot of that. And I think, Bella, in your research too, you saw a lot of the pathologization of youth who've experienced trauma just being slapped a diagnosis of oppositional or conduct.
Yeah, there are 3 things that I want to say. The first thing is, first of all, just thinking about how aligned the comments in the chat are with everything that you just said, Ali. So Paula says that there's so many cultural, monetary, and other barriers to getting a diagnosis, but diagnosis is necessary for so many safety net programs. And this is exactly what Ali is talking about. There's also a double-edged sword. If you want treatment for your mental health diagnosis, you need the diagnosis, but once you get it, there's stigma. This is exactly what we see, right? When we think about something, for example, like oppositional defiant disorder, and the work that I'm doing right now, right, I'm finding that ODD is the most common diagnosis that foster youth have. But so often the things that get them, marked as oppositional or as defiant are responses, very normative teenage responses to extremely difficult situations, right? A teenager that's been removed from their home, who refuses to talk to their social worker because the social worker represents the people that remove them from their community. And so the social worker who's conducting the assessment marks them as ODD because they refuse to talk to them, right? They see them as oppositional, as opposed to recognizing that actually this youth is somebody that has had all control taken away from their lives, right? So how can we see these kind of acts of defiance, right? These oppositional acts as something that is maybe based in agency, as something that is more based in a need to feel control in their own lives, as opposed to, an immediate pathologization. Or when we're thinking about, gender affirming surgeries, right? And the need for a gender dysphoria diagnosis, and how for some trans people, I think that there's a kind of preconception that all trans people navigate gender dysphoria. That's not true, right? There are actually a lot of trans people that don't deal with gender dysphoria. And so having that diagnosis in order to be able to get the gender affirming treatments that they need can be a really off-putting or a really kind of isolating experience for them, right? So this means that we have to be willing to have conversations about the diagnosis. What do you understand about what you've been diagnosed as? How do you feel like it's impacted you? Do you feel like it's accurate? What are your thoughts about it? Mm-hmm. And, I think that with all of these kind of categories, there are so many ways that we can explore these things again, right? It's not necessarily a checklist, but it's a willingness to engage in an exploration. And then Paula again says, specific diagnoses are named in the act as targets. So getting that diagnosis may get you help, but may also get you loss of your civil rights and basic freedoms. And all of this is happening at the same time that the Free Britney movement is happening. So we can definitely think about conservatorships, right, as part of this conversation. And then Meg says, I attended a webinar on brain damage yesterday, another intersectional issue in looking at trauma, learning disabilities, ADHD, and other behavioral health issues that often lead to justice involvement. It would be helpful to look at common symptoms, discuss at some point how misdiagnosis impacts youth. Oh, there are so many ways, right? In the work that I'm doing, what I see is that an ODD diagnosis actually has a really huge impact on the placement that youth who are on care get access to. So often resource homes don't want youth who have an oppositional defiant disorder diagnosis. And so what that means is that the very few resource homes that we do have available in Santa Barbara County are now not an option for kids that have ODD, right? So there's this kind of ongoing impact that the diagnosis has on their lives that so often we don't think about. All right. Oh gosh, we have so many good things in this. And then Will says, oppositional is like when the cops grab you up and twist your arm up your back and say, stop resisting. Exactly, right? There's this idea that so the project that I'm doing right now is specifically with foster kids, which is why I keep going back to the foster youth population of Santa Barbara County. But there's this kind of narrative, right? That, oh gosh, these kids are just, really, they're difficult. They have these outward behaviors. They're really defiant. They're not listening. They refuse to talk. They refuse to come out of their rooms. I've worked with some kids who have gotten in trouble because they isolate. Right. And so even that isolation is seen as oppositional, it's seen as defiant, when actually, right, the issue that they're dealing with is this much larger system that has removed them from their communities. And now I understand, there are youth that are taken out of homes because they are abusive. But what would it look like if we had responses that were based in the communities that they are familiar with, as opposed to taking them out of everything that they know? Or even what would it look like if we recognize that these kids are navigating, extreme isolation, extreme lack of control. So behaviors have to be expected. And then Luna says that the largest obstacle is navigating their own health. Often our mental health leaves us feeling overwhelmed. Oof, say that, yes. Unable to keep up with work and bills and relationships. This often requires more time off because we become exhausted. When a client is in crisis, the battle becomes getting them out of bed and making the most of these precious bursts of energy. Because of all of this, many people acquire debt and more stress as a result of companies and debt collectors being unwilling to accommodate people. You're literally, Luna, go off. You're speaking exactly to the ways that capitalism create these kind of systems that make it impossible for people who have, navigated kind of historical discrimination, make it impossible for them to have human reactions to the things that they've dealt with, right? If we're not working, then we're not living because we can't pay our rent, right? So there's this idea that without the ability to work, then, the kind of usefulness that we have in the world diminishes, as opposed to giving folks an opportunity to recover, to navigate mental health without the stress of rent. And now I know that these are really big conversations, right? And part of what this goes back to is a lack of resources in so many communities. And I would love to hear about how folks navigate this kind of lack of resources, because I know that if we're dealing with it in Santa Barbara County, that y'all are also dealing with it in the counties that you're working with. All right, if we can, thank you all so much for that. That was, yes, super insightful. If we can move on, thank you. All right, so religion and spiritual orientation. This has actually been an incredibly humbling category for me. I was raised Roman Catholic. I have really specific ideas about, and I'm queer, so really specific ideas about what it means to be religious and spiritual that I have had to really change and to really shift in working with queer populations. Let's see, Mariah says, I love this space and appreciate all of the knowledge and content provided. I look forward to the next session. Thank you. Mariah, thank you so much for being here. I know that folks may have to jump off at 11. We will be here until 11:30 continuing this conversation. So if you are able to, please feel free to hang out with us.
Yes. So kind of getting back to this question of religion and spirituality, again, what are important things to consider when working with someone who's marginalized within this identity? What types of hardships may we see? What types of protective factors, privilege may we see? And so again, anyone want to drop in the chat there?
Yeah, and we can pull up the next slide while folks are typing.
I will kind of add to this that, again, in working with this population, I think very often there is an assumption that if you identify somewhere along the LGBT spectrum, that you do not practice a religion. And I'm guilty of this myself. I got referred in one of my first cases in New Jersey. I got referred, just a white woman, didn't say anything about her sexual orientation. It was just that she is kind of experiencing culture shock as she had moved to New Jersey from, was it Utah? And she identified it like religion-wise Mormon. And so I had these thoughts of like, oh my God, I have to meet this person. I present very queer at this time. I was, going by she, her, dressing masculine. And I'm like, and I'm supposed to help this person who's struggling with culture shock as the therapist. So I go and I meet her, and I did not ask anything about sexual orientation because I just thought, oh, she's Mormon, she must be straight. And then as we get to like, well, what brings you in, and like, what are you navigating around experiencing culture shock? And she said, I've just left home for college, and I'm having queer desires, and I think I identify as a lesbian, but I'm struggling because I don't know how to balance this with my religion. This is how I grew up. This is a huge part of my identity. And so I was taken back. I was shocked. And in my head, I was kind of like, wow, I can't believe you didn't ask that. Like, you were just going to ignore that question of like, how do you identify in terms of sexual orientation? Just because you assumed that based on her religion, that wasn't even something I should be assessing. And so the work we ended up doing was helping her accept herself as a lesbian, but also honoring the many things that she loved and appreciated and wanted to keep about her religion. So definitely I'm guilty of making assumptions there just based off one bit of information of like religion.
And I think that this is, something that many of us could potentially be guilty of. As somebody that had a very ostracizing experience within religion, I don't do this anymore, but I found myself, going into the situation, talking to other queer folks with an assumption that they also had separated from their own religious institutions. And what ended up happening was I closed off the opportunity for conversations, because actually I now know that I have a lot of queer friends who are incredibly religious and very spiritual, and it's actually a source of strength for them. It's a source of community. It's a source of connection. And then I see that Leslie says, challenge. Too often our connection to our faith is pathologized in treatment settings, 100%.
Yeah,
I think that can be very true. I think that especially if, and this is again where this kind of self-awareness comes into play, right? Because in the example that Ali shared, he's coming in with his own ideas, with his own experiences around religion that kind of close him off from exploring these questions with somebody else. And so when it comes to religion, there are so many assumptions that we need to be sure that we're not making, right? We have to be willing to explore this. We have to be willing to explore whether this person has a positive experience or a negative experience with it. And when we're thinking about something like religion or spiritual orientation, we also have to be thinking about the ways that something like race is going to impact somebody's experience with this, right? If somebody is racialized and they're also Muslim, especially if they have visible markers of their Muslim religious identity, right? If they're maybe hijabi wearing, then we know that the kinds of discrimination, especially in this post 9/11 United States, that they're going to be dealing with are going to be very, very different than somebody who's maybe a person of color and Christian. So these questions around religion have to be something that we're willing to explore, because for many people, it can either be a source of connection and of, this incredibly healing well of community, or it can be something that has been really detrimental and really painful for them. All of this to say, we don't have to know everything again, but we do have to be willing to explore.
Right, I think I just want to point out here on your little slide, we have research suggests that Religion reduces suicide rates, alcoholism, and drug use. I will say I had a Black woman come into the clinic, and here in Santa Barbara, the Black population is like, what, 2%. And so she had just moved here, leaving a bad relationship. And she's like, I don't have anybody here. She was experiencing suicidal ideation, hopelessness. And, and asking about, how do you identify in terms of religion? She shared that, yes, she identified a particular way. And there just so happened to be a group down the street from the clinic where there is a large Black population that attends this church. And, she came in a couple sessions later and she's like, oh, just so you know, I went to that church you recommended and I found friends, and she is now thriving. And it's, again, something I wouldn't have typically suggested. But again, as I've become to like take a more intersectional lens in my assessment, these were questions that were asked instead of assumptions being made or avoiding. And then turns out, yeah, she tapped into this community and she has not had, nearly the amount of suicidal ideation that she had when I first met her. And I've been working with her for 8 months. Now she's getting married, she's having a baby, and she goes to church every Sunday and Bible study and group multiple times a week. So it's been a great resource for her.
Yeah, so really recognizing that, in community, like, Santa Barbara County is a semi-rural community. There are a lot of racial disparities and inequities, a lot of economic inequities. And so in places like this, right, figuring out what are those pockets of community that we can tap into. There aren't many, but they do exist. And for, in this situation, it happened to be a religious community that became a source of huge support for this person. All right, folks, please feel free, if you think of anything else that maybe comes up to you, feel free to drop it in the chat. We can always, go back to any topic. And if we can move on
to last thing I'll say on that slide, we don't need to go back to it, but I just want to say, like, in my own family, right? My family practices, they're kind of split now, but they're Catholic and Christian, and they have used religion to justify very toxic and unhealthy relationships, right? As a woman, religion says this and that. And so I can just see in my own family how religion has been kind of used to justify the mistreatment, the abuse. And I got a lot of aunts and tias in my family that are like, well, you can't give up on your marriage. You have to keep trying. So it is something I see here with married women who come in very often. And that is kind of the narrative. Like, I've been dealing with this for years, but because of religion, because of my faith, like, these are things and so again, just finding ways to honor that balance of, like, I hear you with your religion and what they say and what you need to practice. And at the same time, how can we make this situation less harmful and more healthy? Whether that's improving communication. So not working to to shame the religion and say, no, that's not how it should be. But instead helping them find this balance. So kind of going back to what you all are saying about, like, meeting them where they're at, right? This is the community they've grown up. This is what they believe. And although I may think, because of my own personal experience, that, you shouldn't put up with that, like, you should leave. No, I have to honor that and have ways to have discussions that can create change while still honoring their religion.
Right. And Ali, what that highlights for me, right, is that this person is trusting you and naming the things that are important to them, right? And when we do what Leslie says, right, when we pathologize that experience, when we pathologize their connection to their religious communities, as opposed to listening to what they are naming is important to them, we're closing off this opportunity. And Ariel says that personally, they were raised Southern Baptist and their partner Roman Catholic. Both of them have disconnected, not for any traumatic reasons, but purely because it's something that neither of them connected to. So really thinking about how, because it's something that isn't important to us, we can sometimes cut off that conversation, not prompt that conversation, or just generally, not be something that we're even thinking about. We have to be willing to explore these areas, right? Even if we feel like they're not very important. Or, one of the things that came up in the research that I was doing was I was working with a trans youth who none of their clinicians and nobody that they had ever worked with had ever asked them about their religion because they were trans. Right. So they assumed that there was this kind of disconnect when actually it was really, really important for them. And it was this missed opportunity to help them build connection in a moment where they were feeling incredibly isolated. We have to be willing to ask, maybe it's nothing for them. Maybe they're like, no, screw religion, but we have to be willing to explore. All right, again, thank you all so much for your engagement. We will move on to ethnicity and race. And I know that we all have so much, when it comes to this topic specifically to think about. So as y'all are thinking, dropping in the chat your experiences and your ideas, we will move on to the next slide.
And Ariel, I appreciate you dropping into the chat as well. All right, so now we're going to switch over to ethnicity and race. I imagine this is going to be a pretty good discussion here. So yeah, as you all think of things to say in that chat, Bella, anything you want to say on that?
Yeah, I feel like when it comes to race and ethnicity, right, this is actually, I think that we, in this presentation, we have these all as they're kind of, as kind of isolated categories, but actually all of these categories of identities are things that overlap with each other, right? So in all of the categories that we've already been talking about, race and ethnicity has to be something that we're also considering. We know, right? We know that racialized people experience criminalization at significantly higher rates than white populations. We know that this is even worse if the population is Black. We know that culture and context are significant in recognition of mental health concerns. There's so much when we're thinking about ethnicity and race that we have to consider. And I think that one of the things that often gets left out of this is experiences within mental health systems that have been impacted by racialization, right? There's now so much research coming out about the ways that, for example, anti-Blackness exists within medical communities to the, extreme detriment of, Black birthing parents, for example, right? There's, really high rates of infant mortality. So what is their relationship with things like medical systems, like mental health services? Historically, what have their experiences been? Is there a distrust of these systems, right? Because for so many people, they've been navigating this kind of historical discrimination from these long-standing institutions. So what has that relationship looked like? And is there repair that we need to do?
Yeah. And as we wait for those to drop into the chat, I want to say when it comes to ethnicity and race, right, and thinking about the trans population, I had a discussion with a Black trans man, and he came in, and one of the things he was talking about, as we process what it's like to go through this journey of transition. And so one thing he said was, I've lived most of my life perceived as a Black woman, and I was the most mistreated person, the most undesired person. And so he's like, and now as a Black man, I am the most scariest person walking through my neighborhood. And so that was something that he had to process with me, was what it's like to move through the world as a Black woman to now a Black man, and what kind of shifts had happened, right? He went from being invisible as a Black woman in many ways to being hyper visible as like a Black man in this context of like safety. So it was just like an interesting conversation we had, but again, something I wouldn't have thought of. So when I think of race and ethnicity with trans populations, again, we got to think about, how one moves through the world as a white woman and transitioning to a white man, or a Latino man transitioning to a Latino woman. We're going to see that race and ethnicity kind of play a big factor in the way they experience that and navigate the world.
Or even thinking about, that's a really good point, Ali. And what that reminded me of too was of experiences with, these kind of long-standing experiences with something like racism, right? We have all of this research now that talks about something called weathering. And what that means is that for people that navigate racism for a majority of their lives, there are physical impacts on the body, right? There are higher rates of blood pressure, higher rates of heart attacks, more physical ailments that people that deal with overt racism or even covert racism throughout their lives deal with. So if we're thinking about, maybe a poor family that is also of color, who already has, limited access to something like their medical needs, experiences with racism are going to exacerbate their needs for medical support. And if they don't have access to that, how is that going to continue impacting their ability to access wellness? And Will says, I'm navigating an experience now with a group changing tone when a Black man entered the group. A white woman made statements separating two areas of town and calling one ghetto. So much loaded language, right? The word ghetto is an incredibly loaded word. The director took it as being about a word only and an incident rather with no context. When challenged, she cry talked. Ooh, yeah, those tears, right? She cried, talked, and then went into how she helps needy people. All the attention went to the white woman. The stress of communicating with the white female director about the bigger fix needed is going home with me daily. And I think that what Will is pointing us to right now are exactly the power dynamics that exist within groups with different racial identities, right? So when somebody is of a marginalized racial group, bringing an issue like this to somebody that is in a position of more power, right? They're the director, but not only are they the director, but they're a white person and they're a cisgender woman, right? So there's all of these power differentials at play here. And when we respond out of a place of emotion, right? When we take it as an attack, when we cry because we feel so bad, what we're doing is we are shutting down the opportunity for the people with less power in that room to name what it is that is actually happening. And so, Will, I think that what you're pointing us to right now is really important, right? Because this is part of the awareness. What power dynamics am I bringing into this room, and what will my response mean for the people that are bringing these concerns to me? And then Meg says that in the readings and webinars I've attended on justice involvement, I have found little information on the Latinx community when addressing racial cultural issues. Seems like a big gap in information available and being addressed. You're absolutely right. This is what I find in my work too, is that there's a really big gap when we think about the criminalization of Latino populations. And I think part of that is because there's this kind of overlap, right, between immigration and criminalization and culture within spaces like California that have really big Latino communities. And so, we have research maybe that'll focus on, immigration detention, with very little that looks at something like, detention that is not related to immigration. We have all of these overlaps that don't separate these experiences. So Meg, actually, I would love to talk to you about this because this is something that I see all the time too.
And that's why you're doing this research too.
That's exactly why I'm doing this research. All right, let's move on to the next one. I have so many things to say, but we will keep going. All right, same thing with sexual orientation. As y'all are thinking about it, Ali and I will talk because we love to talk. So if you can put up the next slide for us.
With sexual orientation, right, I just want to throw out, like, ask these questions, assess it, right, but don't pathologize it, because like the Trevor project data that we reviewed early on in sessions talked about how a lot of LGBT folks kind of were hesitant to seek treatment because of fear that someone was going to try to change their sexual orientation. And then we think of like the history of conversion therapy, or even what's on this little slide here, that distrust of mental health services because being gay or lesbian was considered a mental illness up until 1973, but now we've changed it to be gender dysphoria, which is problematic in many ways. But yes, don't hesitate to explore these areas. And also, yeah, like I said, don't pathologize. I think of my own experience. When I was 15, I came out as a lesbian, and I remember having a discussion with a therapist. I had just kind of started therapy, and she was kind of asking me why I liked women and where did that idea come from. And I was just like, I don't know. That's just how I am. And then she said, well, weren't you sexually abused? And I was like, well, because she knew because my assessment. And I was like, well, yeah. And I'm struggling to make the connection here of like, well, how does me being sexually abused have to deal with my like sexual orientation? And she was like, well, yeah, that could have been the reason that you're gay. And I can tell you that was the last time I attended a session with her. And I did not go to therapy for another 8 years until I was 23. So just that statement right there kind of threw me for a loop and made me very hesitant and skeptical of the mental health field.
And
so
I
that's
think
just kind of an example.
One of the things that I want to say, we have 10 minutes left, so I want to move on. But one of the things that I think is really important when we're thinking about something like sexual orientation is that so often when somebody presents as heterosexual, we don't even ask this. We don't even explore things related to sexual orientation or gender because we make assumptions, well, this person's obviously straight. And again, this leaves out an opportunity to have these kind of really nuanced conversations about things like gender. And actually, we can move on to the gender slide. It's the last one. We're going to have to skip a couple of these. And again, if you are interested in having more conversations, email me because I love to talk. So I'm happy to discuss any of
in the chat. Violence against Latinx communities. Sounds like that's kind of in response to someone in the chat had said that there's very limited info. So thank you for dropping that. And again, it's great to have these discussions in group because again, one brain is good, but multiple brains is even better. So thank you.
Yeah. Again, y'all are a source of an incredible resource for each other. So thank you so much for that, Tom. But when we're thinking about, for example, things like sexual orientation and gender, there tends to be this kind of unwillingness to explore these topics with people that present as cisgender or as straight. When actually, even if the person is cis and is straight, they still have experiences with gender. You know, I think that when we talk about gender, we think about it in relation to queer people, to trans people, and to women, right? But men also experience gender. They perform gender, they're impacted by gender. And so when we open up the conversation around gender, it gives us an opportunity to really understand how this social construction has impacted the ways that folks move through their lives. You know, with, for example, you know, in interviews that I've done with with foster boys, part of the conversation that comes up is around the ways that they've learned to move through the world because of their gender, right? So what it means to be a man, what it means to be strong, what it means to be, you know, this kind of perfect specimen of a man, and how that really ends up impacting them in all of these really nuanced, difficult, harmful ways. So when we're thinking about gender, it's important for us to explore it with everybody, not just with people that we see as queer.
Yeah.
Next slide, please.
I want to say, as a supervisor, I was helping, you know, part of my supervision was to help those develop interventions that would, you know, provide rehab to the youth. And I had one Latina worker come in and she said, well, he's a Black boy. He's not going to be open to these worksheets. And I said, well, why do you think that? And she said, because he's a boy. He doesn't like arts and crafts. And I was like, well, has he shared that with you, or is that an assumption? And she's like, well, most boys don't like that. And so anyways, I encouraged her to just try it anyway. And she came back and she's like, he loved it. He loved doing like the arts and crafts part and actually requested more of it. So just an idea of how that gender really stopped my staff from being able to like engage a person in some really good interventions. And I think as I have been on my transition, in my career, I have also seen a shift in the way that folks respond to me walking into a room with, for example, Latino families where I've walked in as a lesbian and it's kind of like, you know, kind of dismissed. But when I walk in now, they perceive me as male, right? And I identify as male. And so I can tell you there's been like, oh, listen to him, like he knows what he's talking about. So at least in my experience here in Santa Barbara, there has been some validity to like what I say now as a man versus when I was perceived like lesbian girl. So just kind of showing that how gender played out in the way that I was able to interact with folks.
And what that tells us, right, about the dynamics that this person is kind of is thinking about. And Joanna says that we have to get away from the notion that those things, that is gender and sexual orientation, are fixed. This is so important. You know, I find that very often with queer youth who are exploring their identities, they get framed as kind of, you know, confused. They don't really know. I don't know. They used to be bisexual and now they're a lesbian. But these categories, exactly like Joanna is saying to us, are not fixed, right? People have to be able to explore them without the risk of being pathologized. People have to be able to name things like gender and sexual orientation for themselves and have to be able to have space to change those things if it's not working for them, right? Or if they're, you know, interested in exploring a different identity. None of these categories are fixed. And when we come into these ideas, or when we come into these conversations with this kind of idea that, well, like, weren't you a lesbian? And with these kind of pathologizing statements, what we're doing is we're closing off the door to conversation that will allow us to explore not just their gender identity, but the way that gender has impacted the ways that they understand power, the ways that they move through the world.
We got a 5-minute check here. So
okay,
we got to wrap up because we want to get your feedback. But all this to say is use the handouts we provided, the two, and these can be great, you know, all staffs to have with your staff, great conversations to have in supervision as you get to know families. So feel free to use all of this knowledge. And again, the goal of today was to really expand our understanding and give different perspectives of how these identities, these layers of identity can impact those we work with, but also impact the relationship we may have as we come into a room with these kind of identities put on us as well.
And then this is the link tree. All of the resources that we've discussed today, including the addressing worksheet and a more simplified version that you can use with your clients, are on this link tree. So please do feel free to explore them, download them, use them for yourself and for your agencies and the folks that you're working with.
And then I do hope you all attend our next session in 2 weeks, because this is where we're actually, now that we've had a lot of discussion and built up to this, we are now going to be diving into the toolbox. So I will be teaching you all some easy to use in the moment EMDR and DBT skills that can help with emotion regulation and overall reduce crisis from happening again.
Well, with that and being mindful of everyone's time, we just want to thank you so much, not just for joining us today, but for the work that you're all doing in your
Thank you.
communities.
Have a good one, everyone. Take care of yourself.
And